All right, today we're diving deep into two really critical pulmonary pathologies, lung abscess and pleural empyema. Now, they can sound alike, but telling them apart, absolutely crucial for treatment. So we're going to walk through the whole clinical pathway, from diagnosis to figuring out which bug is causing the trouble, and finally, how we can nail the therapy for these tough cases.
Okay, so first things first, what's the difference? Think of it like this. A lung abscess is an infection inside the lung itself. It's basically a pocket of dead, infected tissue that creates a cavity right there in the lung parenchyma. But a pleural empyema? That's an infection around the lung. It's when pus fills up that tiny space, the pleural space, that sits between the lung and the chest wall. You've got in the lung versus around the lung. And honestly, getting that location difference down is the key to understanding everything that follows. And just so we're clear about how serious this is, look at that number, 4 to 20%. For pleural empyema, that's the mortality rate. It can climb as high as 1 in 5 people, depending on their age and other health issues. So yeah, this isn't some minor cold. We're talking about a life-threatening condition that demands we act fast and get it right.
Okay, before we get into the really dense stuff, I have to share this. Why did the bacterium break up with the fungus? Because there was just too much mycelium between them. Yeah, I know. All right, terrible jokes aside, let's get back on track. So, here's our roadmap. We'll look at the destructive duo themselves, how to unmask the pathogen, line up the usual suspects, talk targeted therapy, and then cover complications in control before we wrap with a quick knowledge check.
All right, section 1, the destructive duo. Let's lay the groundwork. Moving on to section 2, unmasking the pathogen. Because, you can't treat what you don't know you're fighting. This is all about nailing the diagnosis. Okay, this part is absolutely critical. Precision is everything. When you're sampling that pleural fluid for a suspected empyema, you have to be meticulous. You aspirate the fluid, about 5 mils. And here's the kicker. You inoculate your culture bottles right there at the bedside, both aerobic and anaerobic. Don't wait. Then you send a separate milliliter for a gram stain. Getting this sterile bedside procedure right is the difference between a useful result and a contaminated mess. And this just goes to show you can't just tick a box for culture. The approach has to be so much more tailored. Your clinical suspicion drives the whole process. Think it might be nocardia? Then you better get a deep sample like a biopsy, and you'll need special stains like a modified Zeal-Nielsen. But what if you're thinking of an atypical bug like mycoplasma? Forget culture. You're going straight to molecular diagnostics, to PCR. Every single choice here has to be intentional.
All right, section 3. Let's meet the microbiological lineup. Who are the usual suspects here?
When you're trying to figure out the pathogen, the patient's story is everything. Context is king. If someone gets this out in the community, you're probably thinking about anaerobic flora from the mouth, right? Aspiration. But shift that same patient to the ICU, and your brain has to immediately pivot to hospital-acquired nasties, Acinetobacter, Pseudomonas. See a patient who just got over the flu? Staphylococcus aureus should be flashing in your mind because it loves to cause abscesses post-influenza. And for an IV drug user, yes, S. aureus is a huge suspect, but you also have to be thinking bigger. Could this be septic emboli from right-sided endocarditis? Okay, section 4. Targeted therapeutic strategies. And let me say this loud and clear before we even talk about a single drug. Antibiotics are not the first step. The single most important, absolutely non-negotiable part of treatment for both a lung abscess and an empyema is drainage. You have to get the pus out. So once drainage is established, then we bring in the big guns. This table gives you a great starting framework. For your classic oral anaerobes, a combo of high-dose penicillin plus metronidazole is the go-to. Got Staph aureus? You're reaching for fluocloxacillin. But look at the durations here. We're talking 2 to 6 weeks. And for something nasty like nocardia, you could be looking at 3 to 6 months of therapy. These are not quick-fix infections. They demand prolonged, targeted treatment, and ideally that treatment is guided by what your cultures and sensitivities tell you. Now, kids are not just little adults, especially neonates. things are different. For a baby who develops pneumonia in the hospital after a couple of days, your empiric coverage has to be broad. Think cefuroxime plus gentamicin to cover the likely culprits. Then there's this other tricky situation, urea plasma pneumonia. Since it can cause long-term lung issues, we often treat with erythromycin for about a week, sometimes even before we get that definitive PCR result back. Section 5. Complications and control. Because what happens in the lung, unfortunately, doesn't always stay in the lung. Let's talk about the fallout. And this is why we take it so seriously. Of course, there's the risk of respiratory failure, but the real danger is when these bacteria go systemic. They can see the heart, causing endocarditis. They can cross the blood-brain barrier, causing meningitis. They can lodge in the spine, leading to spondylodiscitis, or in joints, causing septic arthritis. And then there's the absolute nightmare scenario, descending necrotizing mediastinitis, a catastrophic infection that travels down the tissues of the neck into the chest. It's devastating. And even if a patient survives all that, the inflammatory storm they've weathered leaves a mark, leading to a higher risk of cardiovascular events down the road. Here's a really important prevention point. Patients without a spleen. You have to remember, the spleen is like the body's bouncer. It's brilliant at filtering out encapsulated bacteria, like pneumococcus and H. influenza. Take that filter away, and those bacteria can run wild. It leads to something called OPSI, overwhelming post-splenectomy infection. It's an incredibly rapid, fulminant sepsis that carries a shockingly high mortality rate. So, any patient with a history of splenectomy who comes in sick, your alarm bells should be ringing. And this brings us to our broader responsibility. It's not just about the one patient in front of you. Some of these pathogens are a public health concern. Think invasive group A strep or Bordetella pertussis, whooping cough. These are notifiable diseases. That means reporting them isn't optional, it's mandatory. It's how public health officials can spot an outbreak, trace contacts, and put measures in place to stop it from spreading through the whole community. Okay, last section. Let's do a quick clinical knowledge check. I've thrown a lot at you, so let's see what's stuck with a few quick-fire scenarios. First up, a 55-year-old with liver cirrhosis develops spontaneous bacterial peritonitis. What's the most appropriate empirical antibiotic regimen? Is it A, flucloxacillin, B, meropenem, C, cefuroxime and gentamicin, or D, metronidazole? Give it a thought. The answer here is C, cefuroxime and gentamicin. In SBP, you're primarily worried about gut bacteria, like E. coli and Klebsiella, and this combination provides excellent coverage for those common culprits. All right, next one, an IV drug user comes in with pneumonia and empyema, and they're not getting better on the usual antibiotics. Who is your number one suspect? Is it H. flu, Mycoplasma, Staph aureus, or Legionella? Think about the risk factors. The answer has to be C, Staph aureus. The trifecta of IV drug use, an infection that's forming pus pockets and not responding to standard therapy, that just has S. aureus written all over it. And you got to be thinking it might be seeding from right-sided endocarditis. Last question, and this one's a big one for diagnostics. What is the absolute gold standard for getting a sample from a suspected lung abscess? Is it just a sputum culture, blood cultures, drainage and culture of the aspirate material, or a throat swab and just starting antibiotics? The answer, and this is a take-home point, is C, drainage and culture of the aspirated material. Period. Getting a direct sample of the pus and doing it before you start antibiotics if you can is the single most important thing you can do to figure out what you're fighting and how to kill it. So I want to leave you with one final thought. We've just gone through this whole beautiful, structured, evidence-based clinical pathway. But as antimicrobial resistance keeps changing the game, which part of this pathway do you think is going to break first? Will it be our ability to diagnose things accurately? Will our empiric antibiotic choices just stop working? Or will even our targeted therapies become useless? That is a question we are all going to have to answer sooner rather than later. Thanks for tuning in.